Hello, I'm Dr. Alison Walker, Chair of JRCALC, or the Joint Royal College's Ambulance Liaison Committee. The JRCALC Clinical Practice Guidelines are the established clinical standard of practice for ambulance clinicians. They're an essential resource for paramedics, providing guidance for the assessment and management of patients and supporting ambulance paramedics in carrying out their role. The full guidelines can be accessed digitally via the ICPG and JRCALC Plus apps, and also in our print version. We've just released our latest set of guideline updates, and I'm here to give you a detailed outline on the updates that have been made. They've been included on both apps and also in the newly released 2022 print edition. So first of all, we've added 3 new guidelines. After a number of requests from paramedics across the UK, we've introduced a new guideline on low back pain, which is thought to be musculoskeletal in origin. This includes guidance on the assessment and management of this common presentation and also includes differential diagnoses, red flags, serious pathologies for hospital conveyance, and guidance on those patients that may be suitable for community management or referral to primary care. It also includes advice on pharmacological and non-pharmacological pain management and advice on simple exercises and safety netting. We've also included a new guideline on human factors, which is included in the general guidance section. There's now plenty of evidence that human factors have a major impact on patient safety and clinical outcomes, and a short section on human factors will remain in the out-of-hospital cardiac arrest review. The last of the 3 new guidelines is the Chemical, Biological, Radiological, Nuclear, or CBRN, which includes Hazardous Materials Guideline. This is new guidance which will be in the Special Situations section and includes information on safety triggers for emergency personnel, including STEP 123+, the use of the CREST tool, which looks at consciousness, respiration, eyes, secretions, and skin changes, and more about specific agents, including nerve agents, cyanide, opiates, atropine toxicity, corrosive substances, and on individual chemical exposure or ICE conditions. It also includes more advice on ionizing radiation exposure and decontamination and illicit drug labs. We have also made a number of significant updates to existing guidelines. The first of these is the use of adrenaline 1 in 10,000. And we've included indications and doses for the return of spontaneous circulation following cardiac arrest. Although 250 to 500 mL of IV or IO fluid may support the circulation, it may take several minutes to administer. If hypotension is present during or after this fluid administration, we can provide additional circulatory support using careful administration of an adrenaline bolus, repeated as required every 3 to 5 minutes to maintain the systolic blood pressure at over 100 millimeters of mercury. We've included details on the initial and subsequent doses of adrenaline for post-ROSC care in the guidance, and that following each adrenaline bolus, there must be a flush of 20 mL of normal saline. We've also updated our guidance on the use of glucagon. This will no longer be used on babies at birth because they don't have any stores of glycogen, so glucagon does not work for this group of infants. We've updated our Ondansetron guideline to include repeat doses, as we know that some travel periods are long and paramedics may also be providing care for patients for long periods in other situations. Congenital long QT syndrome has also been added as a contraindication to the use of Ondansetron. For the Prednisolone guideline, glaucoma, recent MI, and breastfeeding have been moved from a contraindication to a caution. Our DuoDote guideline has been removed and is now incorporated into the new CBRN guidance. Following feedback from paramedics, we have also amended the guideline on the use of nitrous oxide and thoracic trauma to make this more specific. New wording has been added after feedback on the need to clarify any contraindications in chest trauma. The guideline now says, do not give nitrous oxide for patients with chest injuries and a clinically suspected pneumothorax. We have updated the Ipratoprium Bromide guideline with a new indication, which is for expiratory wheezing. We've also reviewed the respiratory illness in children guideline, including on croup and dexamethasone use. We've removed the modified Thoracic score, as this is no longer advised for patient assessment by NICE. And Dexamethasone is now indicated for children with all degrees of croup, regardless of whether it's mild, moderate, or severe. We've reviewed our guidance on major, complex, and high-risk incidents. This guideline has been reviewed and updated by NARU, who are the National Ambulance Resilience Unit. Our Principles of Joint Working diagram with other emergency services has been updated, and there is inclusion of SORT. We've reviewed the police incapacitant guideline. It's also been updated by NARU and includes updated guidance on conducted energy devices, also known as tasers, and for the assessment and management and removal of taser devices. We've also updated the management of irritant or incapacitant sprays and attenuating energy projectiles and batons. 4 other sections have been updated following changes in national legislation. These are, firstly, domestic abuse guidance, secondly, safeguarding children guidance, thirdly, safeguarding adult guidance, and fourthly, our guidance in relation to the Mental Capacity Act 2005 for those in England and Wales, which includes a new flowchart for assessing mental capacity, which includes new information. In relation to care of the newborn, there's been a document produced by the British Association of Perinatal Medicine called Pre-Hospital Management of the Baby Born at Extreme Preterm Gestation, with a new framework. We have updated our guidelines to map with this new guidance. We've also included new guidance on what's called comfort care for babies known to be born before 22 weeks. Since the last JRCALC edition, the Resuscitation Council of the UK have updated their advanced and basic life support guidance for adults, children and newborns, and we've included these updates in our own guidelines with their permission. As you probably know, there has been a significant amount of work and evidence on out-of-hospital cardiac arrests. In our new guidance, the overview has been updated, and new wording includes information that auditing and reviewing data downloads will help determine how quickly shocks are being delivered. Based on this local data, decisions can be made as to whether to recommend using the AED mode for the first shock in order to minimise the time to first shock and reduce any delays, and local audit data can help inform this decision-making process. The updates to the advanced life support guidance include improved guidance on the use of mechanical chest compression devices and also on the role of ultrasound. Other key changes include the addition of the HOT approach, which stands for hypovolemia, oxygenation to correct hypoxia, and assessment for tension pneumothorax. There's also new information on considering hypoglycemia as a cause of cardiac arrest. It is no longer recommended that a precordial thump is given for the initial treatment of a shockable rhythm, even if a defibrillator is not immediately available. For children, where hypovolemia is thought to be a contributory factor, it is now recommended to give a fluid bolus of 10 mL per kilogram of normal saline or Hartmann solution, which can be repeated once if indicated, and then to seek appropriate senior clinical advice if further boluses are thought to be indicated. For defibrillator shocks, we now suggest a starting energy of at least 150 joules, escalating to maximum output for refractory rhythms. We also suggest quickly shaving the chest prior to defibrillation, which not only ensures better electrical contact and therefore better defibrillation success, but is likely to reduce the risk of electrical arcing between pads, which may trigger a fire. Laryngoscopy remains an important skill for visually inspecting the oropharynx in choking, and we have said this should be part of ongoing competency assessments. Staff attending a cardiac arrest will also need to be trained to provide support to any clinician who's trained to perform intubation, including assisting them in preparing and passing the equipment to them. We have again also reiterated that waveform capnography should always be used when using a supraglottic device. Once an endotracheal tube is in place if used, the guidelines advise the use of continuous chest compressions with 10 gentle ventilations per minute, and also to avoid hyperventilation or high airway pressures during manual ventilation, which have been shown to adversely affect outcomes. In our guidance on basic life support in adults, we've included new wording that the use of a CPR feedback device will allow optimization of BLS delivery and assessment of performance. For basic life support in children, we're reminded that pulse checks might be unreliable and are prone to errors. The detection of circulation should also include other intra-arrest measures such as end-tidal CO2, blood pressure measures, and oxygen saturations. We've updated our guidance on termination and verification of death in adults in line with RC UK. There's a new section on advanced care planning, including more guidance added to clarify decisions around advanced directives, lasting power of attorney, and DNA CPR in both expected and unexpected deaths. The decision to terminate resuscitation has been increased from 20 to 30 minutes after the assessment of new evidence by the Resuscitation Council, where excess survivors were found in the period between 20 to 30 minutes of advanced life support. The guidance now says that if following ALS interventions, the patient has been persistently and continuously asystolic for 30 minutes, and all reversible causes have been identified and corrected, resuscitation may be discontinued except in conditions including pregnancy, hypothermic patients where hypothermia is thought to be the primary cause of the cardiac arrest, in a suspected drug overdose or poisoning, and in those under the age of 18 years old, including infants, children, and adolescents. And there is a specific additional guidance on the termination of resuscitation and verification of death in children. New wording has also been added on the identification of rigor mortis. Rigor mortis is distinct from trismus, which is spasm of the muscles around the jaw, which may also occur in those with a reduced level of consciousness. Rigor mortis is not isolated to jaw muscles alone and is a more generalized condition. In our guidance on the clinical management following the return of spontaneous circulation from a cardiac arrest, we've included new information which suggests that we should aim for a systolic blood pressure of over 100 millimeters of mercury, and we've included the new information on the administration of fluids and adrenaline in detail. There's also new advice that in the event of symptomatic bradycardia in children or infants, we must first ensure that hypoxia has been reversed, as this is the commonest cause of bradycardia in these age groups. There's also now new evidence that cooling patients post-ROSC is not of benefit, but extremes of temperature are still harmful. Some patients post-ROSC will have a mild hypothermia, and we should use no more clothing or blankets than is necessary. Vehicle heating is only required to provide a comfortable ambient temperature. We should aim for a core temperature in these patients of no higher than 37.5 C. There's also improved information stating that adult patients with a cardiac arrest of presumed primary cardiac etiology should be transported directly to a hospital with 24/7 coronary angiography capability. This includes both STEMI and non-STEMI patients. Adult patients with a non-traumatic out-of-hospital cardiac arrest should be considered for transport to a recognised centre of care for appropriate specialist treatment according to local protocols. There is no evidence to express a preference for a policy of primarily transporting by ambulance using bypass protocols or one of secondary into hospital transfer. In relation to the termination of resuscitation and verification of death in children, this has an updated title replacing the previous title of Death of a Child, and now includes guidance for children, including care plans and unexpected deaths. We've reviewed our foreign body airway obstruction guideline, and we've now highlighted that there'll be occasions when a patient has a DNA CPR form may have a cardiac arrest that is considered what is called unnatural, or not in the envisaged circumstances which relate directly to the DNA CPR. And for these patients, there may be a potentially reversible cause, such as choking. In these patients, all reversible causes should be considered and actively managed. And in these circumstances, resuscitation and rapid conveyance to hospital should be considered, as the cause of the cardiac or respiratory arrest is unrelated to the patient's previously recognised main clinical problems and could be reversible. We've also revised the tracheostomy and laryngectomy emergency pre-hospital management, including new management algorithms. We continually review our JRCALC guidelines, including reviews of new evidence, to maintain their clinical relevance and try to ensure that they contain the most up-to-date information. We welcome all feedback through the JRCALC website or through UK ambulance service systems, and also any suggestions for future developments, as many of the changes we've talked about today since the last edition have been prompted by you as the clinicians the guidelines are there to support. If you feel there are any new guidelines or updates that could help you in your clinical practice, please do get in touch with us via the JRCALC website. Thank you for listening, and we look forward to feedback.